because it was really a very cool trial. It was about 12,000 patients, and they had no CVD, so they eliminated the high risk. This was just the medium risk. They were male over 55, female over 65, with one other risk factor. That could be hypertension, diabetes, smoking, family history, and any of those, anyone, but they weren't really high risk. They were medium risk, and they followed them for 5.6 years. The endpoint was MI, stroke, CVD, death, CHF, cardiac arrest, revascularization. Only 1/3 turned out to have hypertension, and so we're going to look at those both together and separately. So this is the results, and what I want you to look at is a couple of things here. First of all, you can see where I put the circle on the screen, a dark line and a red line. And then at the very top, of course, is the randomized control placebo group. And you can see the spread is about almost 30%. But notice this. The red line is virtually superimposable on the black line. The black line is using the whole bundle. The statin, oh, did I read? It was a statin, an ACE, no, it was a statin, a thiazide, and an ARB is the bundle. And that's what they gave to everybody. Versus placebo, of course. And what you can see is the statin alone did the majority of the work. And
it's hard.
oh, I'm sorry. Yeah, so here's the red line. This is the statin.
Okay.
And then this is the black line. Yeah, they're superimposable. Now over here, they're a little bit of a spread on stroke, and we have that so that you can still see that the statin is a very powerful tool in this randomized controlled trial, and we're going to come to deal with that again in just a moment. And I think that's, oh yeah, the other thing is that they looked then at the group that was hypertensive, and indeed the same bundle increased the benefit to 40%. So the antihypertensives added in, it made a difference in the hypertensive patients. It worked through decreasing hypertension. So we now know, we have some good guidelines about which bundle to use in which people. Now, what is the grade criteria? How many here have heard of this grade criteria? Okay, good, great. Grade criteria is something that says, what are the criteria for implementation? That's not how good is a study. And basically, quality of evidence is one of the 4 criteria. And what it says is the higher the more randomized control, the better the quality, the more likely it is that this is true and will be transferable. But these two bring up another really very important factor, and that is a balance between desirable and undesirable effects, and that same thing in the eye of the patient. So if the potential benefit is not having a heart or stroke, and the side effect is having a muscle ache, or if you're on an ACE, a cough, some people will say, I'd rather not have the stroke, I'll take the chance of getting the muscle ache and cough. And so that's the value and preferences and the balance. And of course, when we're talking about treating all the mid-level people, that's a lot of people, cost is always important. We're not going to use the PCSK9s in the middle group. So modeling, what model could we do, and what did it show? And we used a big program called Archimedes, which isn't around anymore, but it combined all of the studies that were prevention in cardiovascular diabetes with all of the meds we're just talking about. And what we found here, this is the run inside Kaiser, it was the effect on morbidity and mortality, and this is on all diabetics. And we used aspirin, lisinopril, and lovastatin, called it all. And you can see this circle. Can you see the circle? Okay. What you see, you notice there's a little blip down the red. The red is A1C alone. And so it turns out that this is actually accurate. It turns out in the ACCORD study, as you know, a 10% drop in heart attacks and strokes. Oops, I'm having trouble with this getting too sensitive. And basically, the only problem was there was way more deaths due to unknown cause, and so we can't use that, we can't go after that 10%. But also, take a look at heart and stroke, it was modeled at 71%. So it really looks like if you don't go after the ALL kind of thing, you're probably not going to be getting much effect on heart attacks and strokes. So inside Kaiser, we sort of did this thing of the grade in our heads because it wasn't around at that time, and said, well, shouldn't we do this? Let's give this a try. And so in 2004, we had 170,000 people with either diabetes or CVD, and 100,000 of them in the next 2 years we didn't get on, but 47,000 we got on the bundle at low adherence, and 21,000 we got it on at high adherence. And what we showed after 2 years of being on the bundle, a 15 per 1,000 drop in the low adherence, and that was equal to about 60%. And of the high adherence, a 26% drop compared to the group that wasn't treated. And of course, it's not a randomized controlled trial, no causal can be implied, but it was in the right direction. So we felt that was supportive. So the only thing is, that was only 14% of our patients we wanted to go after the population. So we said, what about adding in hypertension? How about people with hypertension over 55 years old? And so we did that. We said if the systolic is over 140, over 55 years old, let's model an ACE and add to that a combo pill with a thiazide, and then add to that a statin, simvastatin in this particular model. And so we said, what's the possible good we could do with this model? And what we looked at here on the left-hand side, and you probably can't see that, that's the ACEs alone. And we're looking at absolute fall at 20 years in MACE, and this MACE was heart attack, stroke, or death, just simple. And we saw a nice significant drop, and it was very good. But when you added the thiazide, you actually doubled that drop. But look at this. When you took the statin alone, you did more benefit than either of the blood pressure medicines. And that harkens back to the HOPE-3, remember? The big drop with statin alone. And of course, if you put them together, which is what we're saying to do, you get a quadrupling of potential benefit. Then if you just bring them in, start them on one antihypertensive, go home, come back, and we might do more. So when you look at relative benefit, we're going to look at the relative, again, MACE, heart attack, stroke, or death. And if you just did a thiazide, just an ACE, we got a 25%. Add a thiazide to that, you got a 50% relative drop. Add a statin to that, and you got a 73%. Now this is interesting because the more you lower the risk, then the next drug you add is working on a much lower risk. So this is adding aspirin either to 3 drugs or 2 drugs or 3 drugs, and the benefit drops from the 12% down to 4% with the 2 drugs and 2%. So we bring that to your mind because we're going to come back to that in just a minute. It does work very well on blood pressure, about 10 millimeters with just the ACE, with thiazide, 25 millimeter, add a calcium channel blocker, about 35. Why calcium channel blocker? Because this is what Northern California Kaiser did. And Dr. Stephen Sidney's name is on this, so he can answer any questions you possibly could come up with. But basically, it was that combination pill. So you can prescribe just the one pill and start with a half, go to 1, go to 2, not bring back for another prescription, not go through all of the stuff you have to do. And if that's not enough, add calcium channel blocker. So what happened in Northern California? And Steve, did you show this slide last time?
No. He hasn't presented.
Yeah, okay, you haven't presented. Okay, well, I'm going to present Stephen's conclusion here. And you can see on the left-hand side, the top line is total MIs, and the duration is from 1999 to 2008. And you can see there was a nice 30% drop during that time. The STEMIs on the bottom is 60%. And if you see the line in the middle, it has that blip going up. And they had a troponin diagnosis right around just before the blip. Now, this wasn't a controlled study, so we can only say it's associated with that, but it's possible that that had some effect. Yeah?
to elaborate, could you give me another sentence on the troponin?
Steve, you want to do that?
Because troponin, an abnormal troponin goes into the diagnosis, and so and troponin is more sensitive than like the CK that was being used predominantly in diagnosis before that. So when they added troponin, all of a sudden there were a lot more MRIs because they were abnormal troponins.
They were people who had the troponins done, but they weren't diagnosed until they changed the diagnosis to add the diagnosis. So it confuses the report. Also, look at this. ACE, ARBs, and statins went up during the whole time. Look at this figure. Hypertension control improved from 40% to 80%. Lipids dropped from almost 130 to 113. And so obviously they had implemented these drugs. Again, this is not proof that they work, but it's associated with. Now this was I take my hat off to Steve because this is really important. This is the drop in MI and strokes on this side with patients with heart disease. And this is under 45 to 64 and under 45, both of them more than doubled the benefit. So it was really impressive. In strokes, more than doubled the benefit. Now, when you're a young African-American, 40-year-old, should you get your blood pressure checked? Is it going to be any good if you find it's high and you start taking medicines? The answer is yes. So this is I think, very important contribution. Okay, what if you're diabetic and you don't think you're the 1.8% that doesn't have hypertension? Well, looking at statin effect alone, as you'll see in this cholesterol treatment trialist group, showed that it was the same exact benefit in the people with diabetes as the ones that did not have diabetes. So that for sure they should be on a statin. The heart protection study started a statin, Sima40, the same one we modeled, and showed this nice 22% benefit, and it started at 40, equally as good at 40 and so forth. So diabetic over 40 became sort of evidence-based thing that people landed on. What about aspirin in the post-statin era? And you just saw that data I showed that showed that its total need, its total benefit once you've started a statin and started antihypertensives is a lot lower. And this, Paul Richter wrote a nice editorial after the ASCEND. And the ASCEND is the story, is the aspirin use in diabetics with no other drug showing a nice 12% drop in CVD, but a 29% increase in significant serious bleeds. And so his comment was, and then the Aspire was even a little more equivocal in other primary. In the use in primary disease, it may simply be better to prescribe the statin since the statin does so much more. And USPSTF says if they're 50 to 60 and over 10% risk, consider it if low bleed risk. AHRQ says, yeah, but get the blood pressure under control because if it's high, they have more hemorrhagic strokes and you blew your potential advantage. And the bottom line is you can make aspirin optional. You can tell them the possible goods and the bad and say, go do what you want, you can buy it, you can stay on it, and we're going to leave you alone. So, and stay focused on getting those other drugs that we know are really important. So RightCare, what happened? And let's talk about that. So RightCare said, gee, this stuff looks pretty good. Let's try a pilot in San Diego. And so they send their version of James Bond, whose name is Hattie Hanley, to San Diego because nobody can say no to Hattie Hanley. And so everybody got in a room like this. And Hattie got us in there, locked the door. It was a little hot, 110 temperature. We had to perform. At any rate, so many of us were competitors. We had never seen each other. We had never worked together. I was concerned we might give this thing away to competitors. Is that okay with our leader? Our leader said, we will not compete on quality. Go give it away. We'll do other things. And once we did that, it was catalytic in the room. Everybody opened up. And we got great contribution from everybody. We weren't the only ones. The overriding reason, as they went around the room, it's too important. This is too important to not do. We just have to do it. And the issue then was trust. And so I talked to John Overwright, and I said, John, how is it that, how are we going to build trust? Because I knew he knows everything about that. He said, oh, that's easy. Just work together for a couple of years and once a month. And he was right. It's exactly what it took. We began, because we tested each other and so forth. By the way, we did use a non-disclosure agreement, and if you're going to do something, I suggest you do that. We trusted each other, but it was important to our leaders to see there's a non-disclosure, and it was important that none of the data ever left the room, and it's been not a problem. We decided to do a zero type of approach, as you're going to hear. What did we accomplish? Well, the data are a little more sketchy. 2013 to 2017, we increased blood pressure control from about 70% to about 80%. And of course, that's more than the California average and the national. And in lipids, unfortunately, they changed the criteria from lipid level to being on a statin. So our data only goes from 15 to 17. We got a 12% increase. But I can tell you our uses of statins, the other metric is good. It just doesn't go back very far. Is this an opportunity for you folks? Well, this is the blood pressure control. This looks an awful lot like the first one we saw in San Diego, doesn't it, Hattie? You know, a couple of groups that are high, they kind of knew what to do, they kind of had systems. And all we did was work together, we shared, and everybody came up, including Kaiser. What happened? Well, you've probably seen this already. Have they, Hattie?
No,
Oh,
this
they
is a
have?
brand new group.
Oh, brand new group. Okay, welcome everybody. No wonder I didn't recognize any of you. Okay, so it turns out that in the years between 2010 and 2016, there was a split in the in decreasing heart attacks. They decreased across the state, average in all the counties of 7.6%. In San Diego County, 22%. So what does that add up to? Well, if we'd have had this, only the 7.6, there would have been 3,800 more heart attacks at $85 million more. If this were spread across all of the state, it could be 41,700 heart attacks saved and 935 million. So is it impactful? It's impactful. And I think we've got something. So, okay, very quickly, two more things, because these are actually quite important. What to do if you want to change that medium group. It has to, and this is a quote by Dean Schillinger at UCSF, and I suggest you bring him here, and he gives this talk to you. Replace intensive interventions with low-cost interventions with frequent contact that engage more people. And what are the biggest three factors? Simplicity, simplicity, simplicity. By some guy named B.J. Fogg. Anybody here ever heard of him? Isn't he at a university out west somewhere?
Maybe.
Might be somewhere. Okay. I suggest you have him come and talk to you, but he's absolutely right. It is so important, and a name you don't probably know is Mark Jaffe, but you should, and get him to come talk when he's back in the nation, because he's right now going around the world with Tom Frieden, the ex-CDC head, in a group called Resolve to decrease 100 million deaths in hypertensives. And his experience is exactly that. No step or branch. Zero. None. He can't tolerate one. The bigger the group, the more you're trying to accomplish, you really got rid of variability. Cheap. This is 25 cents a day. Easily implementable. Do all the work for the provider, get the patients in, show them the video before they sit down, show them the graph of the heart, the three things or the two things if you don't use aspirin. And then for the patient, make it worth their while. And the question I usually ask is, do you know anybody who's had diabetes or hypertension that had a heart attack or stroke at an early age? And I don't think I can't remember any patient that didn't remember that. You're at high risk. And you know what, we've got a way we can prevent this 50, 60%, or 30%, whatever number, whichever graph you want to start quoting. Would that be of interest to you? And it tends, and then show them the crack, the plaque, type of thing. And it works pretty well. The other really big important factor, prescribe both pills on the same first visit. Okay, so this is a heart attack bundle. You can see these three things. I'm going to give you the whole bundle right now. And the doctors would tell me, oh, the patients don't want to do that. They're over. No, the patients, if you tell them it's a bundle and works together, they're fine with it. The doctors have a hard time with that. But don't let them get away with that. Now, the other thing is, okay, so I'm going to come to the other thing right now. How about diet, exercise, smoking cessation? Absolutely. By the way, remember there's 40% of the people with 12% risk. They all need diet and exercise so they don't become the medium or the high risk. So number one, you've got a beginning group to start with. But all of these people will benefit. Now, commonly I'll say, I'm going to start this, and oh no, I don't really want to do this. I'll try harder, I'll see you in 3 months, and they don't come back. So I'm saying, no, I really want to do that. And they say, no, I really want to try harder. And I say, I'll tell you what, how about you go 6 weeks at home, do it. Go lose weight, change your diet, change your exercise, come back in 6 weeks, make the appointment today. If you have succeeded, I want to pat you on the back. If you haven't, would you reconsider these meds? So that kind of thing. How to do it. Now this is probably the most important slide, because without paying attention to this, I lost about 6 years of effectiveness. Accountability. You've got to make a practitioner accountable to do those 2 prescriptions. How do you do that? You say, we're going to measure, we're going to metric whether the prescription was written or whether it was filled, whichever way you can. And then we're going to metric refills, whether we can pull the refills in somehow, or we do med reconciliation when they come in. And if you do that, and then you do the follow-up, unblinded peer review, monthly follow-up. This is what we did. Support system to change until it's at target. Continue to monthly go over this until you get there. It took 3-4 years, actually it's been 10 years, as Steve showed it, from beginning to end. If you do that, it will work. If you don't do that, it's really iffy. Okay, so I'm done. Dr. Wong is going to tell you a little bit about what's been already done in community health in the San Francisco area.
Thank you, Jim. Just doing time check. How much time do we have for this part of the presentation left?
Let's see. We were supposed to move at 5:30, but how much maybe take?
Okay, I'll do 5 to 10 minutes,
Yeah.
something like
I
that.
think we should just skip the breakout group so that they can present since.
Oh,
No?
no, do the breakout. It's only 5
5
minutes.
minutes. 5 minutes.
Bye, 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 bye,
I
bye.
don't want to cut.
Well,
Winston
let
short.
me tell you, what you heard from Jim Dudl, I heard from Jim Dudl about 10 years ago, and actually maybe even more than that, during his first retirement. And just to give you some background, I was brought on as the medical director for community benefit with the specific objective of identifying an initiative or a series of initiatives that could translate population health in a way that was meaningful for underserved populations and also leverage the lessons and strengths of Kaiser Permanente. So I stumbled into listening to Jim's presentation, and it was pretty radical. And I did hypothesize, what could we do if we were very intentional about investing in community health centers to take on an approach to reducing cardiovascular risk among diabetics? And we did launch on that program. We launched the program in 2006, and I'm happy to say that the program is still in place and sustainable. And I'm going to give you a little bit of the snapshot of what that entailed. Now, I think probably given this group, you're all familiar actually with community health centers. They're not population groups that are well resourced. They're delivery systems that barely established the electronic health record over the last 5 years ago. Before the Affordable Care Act, when this program was launched, many of their patients were basically uninsured and thus didn't have their medications necessarily covered. So we were dealing with a number of factors that would suggest that the community health centers couldn't possibly be as successful as Kaiser Permanente in launching population health approaches to cardiovascular health. Secondly, too, I think you should remember that many of the patients that access community health centers are immigrant, they're non-English speaking, they're low health literacy, and one could even suggest, well, then this is not going to be a population that we're going to be really successful with in terms of launching a program. But lo and behold, we actually did the program in Northern and Southern California. We had forays in Colorado. We had initiatives also in Portland and some in Virginia and Maryland. We had smaller programs that were established in Georgia. They all had different levels of success. But for the most part, I can tell you this. At this point in California, with all our 18 grantees in Northern California, not to mention about another dozen in Southern California, there's about 200,000 patients that meet criteria that are basically being placed on the bundle as Jim described. There's, of these 200,000 patients, 151,000 are hypertensive, 108,000 are diabetic, 22,000 are considered individuals with coronary disease. So that's a substantial number of patients. So what are we seeing just in Northern California? 77% of those patients in those different criteria are now prescribed a statin, which I believe is considerably higher than in general practice, because to Jim's point, they're getting to patients at medium and high risk, not just focusing on high-risk patients. 60+% are prescribed a statin and either an ACE or an ARB. So the prescribing patterns have really improved. Now, our community health centers, as all of you can also relate to, report in terms of HEDIS rates. So, you know, actually what Jim has described is not embellished or not yet adopted in terms of what you report in HEDIS. But I will tell you, of the 18 grantees here in Northern California, 11 of them are meeting the HEDIS 90th percentile. Better than 90% of all those systems that report on HEDIS for at least one of two measures for high blood pressure control. So that's pretty impressive when you consider what is traditionally thought is a low resource delivery system. In addition, if you look at diabetes measures, 13 of the 18 are at the 75th percentile for diabetes measures, including hemoglobin A1C. Now, they are taking on aspects of behavioral health, as was mentioned with regards to the pitch that Jim described. They're taking on issues of tobacco screening and BMI screening, etc. All to say is that their overall capacity for population health has improved as kind of the dividend in terms of focusing on cardiovascular health. I'll also mention a couple of things with regards to who's involved here, because I'm going to name some here in Northern California that you probably even know of. The Alameda County Health System, Community Health Partnership of Santa Clara. So, right in your bailiwick, John, and then also the San Mateo Medical Center. So these are prominent providers. The Golden Valley Health Center, based out of Merced, California, and Valley Health Team. They are among the 18 grantees here in Northern California. Northern California coined the term phase for this particular program. So if you hear about that, you'll know what it means. It's essentially what Jim described. There's a little bit of variation in terms of some emphasis around looking at behavioral health interventions, but preventing heart attacks and strokes every day is what phase is as an acronym. So just to finish, I think what it's really intriguing in terms of what the safety net has done, because they have adopted the principles of what Jim described in terms of population health, but have also customized it for their population. So in some settings, they use group visits. In other settings, obviously, they use the patient education outreach tools to popularize and socialize